Good evening, friends. I'm Dr. Bansi Sabu. I'm thankful to all the eminent diabetologists and endocrinologists who joined as a faculty. Dr. Sanjeev Pathak, Dr. Parag Shah, Dr. Ramesh Goyal, Dr. Vivek Patel, and Dr. Shrikant Somani. I don't think they need any introduction. They all are eminent diabetologists and endocrinologists of the city. Today we gathered here on this online platform. And then there are many more doctors who join online, as well as at 7 City in Gujarat. There are doctors who joined us on a virtual, it's a hybrid meeting also, in a hybrid way, where they are physically present and listening us on a bigger screen. The idea of keeping this meeting is that where we should use gliptin or SGLT2, when we should use, and why we should use. Should we use them individually or should we use them in combination? We are using for diabetic patients since years sulfonylurea, traditionally metformin is always there, and then insulin. But in last 20-25 years, a lot of newer medication had come. And gliptin was first. In 2008 onwards, we started using this molecule along with injectable GLP-1, which was also introduced simultaneously. But because of its ease of use, less side effects, many of our patients had got the benefit of using gliptin. And then we were having the cardiovascular outcome trial, as it was needed for any other new anti-diabetic medication. If it has to come in a market, then it should have a CVOT trial. And then everything changed after the EMPA-REG outcome trial, which had really changed the paradigm, the way we were treating the diabetes. Now it had become like a first choice of therapy, and with the patient who have established cardiovascular disease. Now things completely changed, and when we got the SGLT2 at a very cheaper price, which is almost anyone can afford in our country. Before that, we were not using SGLT2 so often. Yes, we were using, but not like each and every primary care physician or physician can use it. And recently now we have the sitagliptin, you can say gold standard of gliptin, which has got a TICOS trial, a cardiovascular outcome trial, neutral, not having any side effects on cardiovascular system, is now also available at a price which one can afford easily. And then we have a combination of sitagliptin and dapagliflozin in our country, also at a very lower price. As such, this combination is not available internationally. But internationally, there are molecules with gliptin and SGLT2 inhibitors are available. The confusion with many primary care physicians that this combination, when they should use, should they start each and every patient as a first line, this combination, or even immediately after the metformin. And I'm sure in future or near future, we will have a triple drug combination with metformin, sitagliptin, and DAPA. Then there is an issue that if one drug is having some side effects, like we are seeing a lot of 20 to 30% of our patients with SGLT2 inhibitor develops infection, particularly genitomycotic infection, which they should use, which they should stop. And we had also seen some data that with the combination with gliptin and SGLT2 inhibitor, there was less infection. So these are some of the points which I thought we should discuss. And the idea came in our mind, and then we all met once before a few days, and we decided that we will have a discussion which will be online as well as on hybrid mode, that when, where, and why we should use gliptin, SGLT2 inhibitor individually or in combination. Thanks to ACME for giving us this opportunity, who could gather from all across the Gujarat, more than 125 delegates who are online joined for this meeting. And now with this introduction, let me start with first expert, Dr. Parag Shah. Dr. Parag Shah is eminent endocrinologist of the city of Ahmedabad. He is first endocrinologist, DM endocrinologist who started in Ahmedabad is the Gujarat Endocrine Center. And we all know him. Dr. Parag have many paper publication. He has done DM from a prestigious institute, SGPGI, and then he had also passed DNB too. So now I start with Dr. Parag. Then which gliptin or SGLT2 we should use? That's number one. So because we have many gliptins which are available to us, and there are many SGLT2 gliflozin which are available to us. That's the first very important question. And then which combination is better? Can we have, because we have Ramo with vildagliptin in our country, we have with us DAPA and CETA, which is not available in any part of the world. And then we have with us linagliptin and with empagliflozin, and we have with a molecule called saxagliptin along with DAPA2. So we have 4 such combination. So one is which gliptin, which SGLT2, and which combination should we use? Do we have any data to support that which gliptin is better than this, which SGLT2 is better than other, and which combination is better? That's the first question. If Parag have some slides, he can share. But if he does not have slides, then with 5 minutes, we can ask Dr. Parag Shah on this. And then if anybody wants to have any question, we can ask Dr. Parag. And then I will be also asking other experts, Sanjeev Bhai, Ramesh Goel, Vivek Patel, and Shrikant, if they want to chip in for the discussion. So over to Dr. Parag Shah for which gliptin and which SGLT2. First, we start with which gliptin we should have.
See, I think gliptin, as far as the efficacy is concerned, glycemic efficacy is concerned, all gliptins are almost equipotent. So for glycemic benefit, I think all gliptins are same. Vilda twice a day is not is more effective than Vilda once a day. I think Vilda OD, whatever experience we have, does not match the Vilda twice a day. So if you are giving Vilda OD versus other gliptin, probably Vilda OD has less potent glycemic efficacy. So from glycemic point of view, I think all gliptins are equal. As far as the data is concerned, I think got a very robust data with the CETA and the linagliptin. Both had a cardiovascular neutrality data. So both gliptin for that point of view is very good. The number of patients are more with the TICO study with the sitagliptin. Now about the renal insufficiency, Lina has some data, but there is not a hardcore renal protection data actually. It's a data for the albuminuria reversion or in the early stages, but there is no hardcore renal outcome data. So everybody thinks that Lina is the only drug which we can give in the presence of the kidney disease, but we can give all the gliptins. Only thing that, like CETA, for example, we have to decrease the dose based on the EGFR. So we see lots of patients, I think all of us also would agree, who are on inappropriate dose of a gliptin. Whenever we started, EGFR was different, and when patient comes back after 2 years, 3 years, because of so many reasons, patient's EGFR has dropped, and apparently there is not, it's mainly a pharmacological indication rather than the safety indications. So I think CETA being available at an Indian price, I think in our routine clinical practice, there is not a big advantage of Lina over CETA. So CETA scores over Lina as far as the price is concerned, and all benefits of CETA and Lina are almost equal. So my choice, considering the cost and the data, would be the sitagliptin at present. About the SGLT2 inhibitor, first we talk about the science, then we'll talk about the economics. I think we got a 3 SGLT2 inhibitor with a robust cardio and renal outcome trials. As far as the efficacy is concerned, I think all SGLT2, including Ramo, is having a good or equal glycemic effect. Weight loss effect also is same. Whatever little blood pressure reduction also is same. I think genital mycotic infections also are the same. As far as the data is concerned, if the patient has a established atherosclerosis, we got a data for the EMPA because they had a almost 100% patient with established ASCVD. So it showed cardiovascular mortality benefit and all-cause mortality benefit. At the same time, MPART does not has a secondary prevention data as far as the ASCVD is concerned. So DEPA, for that matter, had a good primary as well as the secondary atherosclerotic preventive data, though it does not reach a very good statistical significance as far as the cardiovascular mortality is concerned. From renal point of view, I think all the three SGLT2 inhibitors are equipotent. For the heart failure, I think all three are equipotent. So if you consider the cost, I think for the majority of our patients who are either obese and or with a ASCVD or a multiple risk factor, patient should be on a SGLT2 inhibitor. And DEPA with all robust data for heart failure, renal, and long-term efficacy data, I think is the best choice at present for us. About the genital myocardial infection being less on a gliptin with SGLT2 inhibitor versus giving SGLT2 inhibitor alone, I think our clinical experience does not show much that there is much of a difference, because most of the time when the both were patented, we used to give the DP4 inhibitor first and then we add on the SGLT2 inhibitor, and there was not much of a difference. So that is my opinion, that genital myocardic does not significantly decrease if you have the combination of this. What about the fixed drugs combination of SGLT2 and DP4 inhibitor? I think DEPA and the CETA with the robust data, though it's not available globally because both are from the different pharmaceutical companies, so we don't have a fixed drugs combination globally available. I think it's a best, one of the best combinations. Second best would be the, or the equal would be the Empalina combinations. Ramo, we don't have any data for SGLT2 inhibitor benefits except the glycemic benefits. So I think that way Ramo does not score over. About the DEXA and the SEXA, I think SEXA has a doubt about the heart failure hospitalization. And we hardly now use the SEXA either alone or in a combination. So I think from Indian point of view, the best combination would be the CETA DEPA at present.
So, Dr. Parag rightly informed about the different leptins as well as in the combination also. I would like to ask Sanjeev Bhai or Ramesh or Vivek, Shrikant, if they want to make any comment specifically.
Yes, Bansi, I fully agree with Parag that Sita Depa probably is the best combination, and I think EMPA and Lina is also almost equally good. The only advantage of EMPA-Lina combination is that you do not need to modify the dose of linagliptin as per the GFR, because you can give it at the same dose regardless of the GFR. But as Parag rightly told, that it is not a very clinical advantage, it is probably more of pharmacological advantage. But yes, keeping that in mind, Empalina is much more expensive than Sita-Depa. So we have both the drugs which are best in their class, Sita in the gliptin group, Depa or Empa in the SGLT2 group. Hardly there is anything to choose between Depa and Empa now, because now both the drugs are having very good cardiovascular outcome data. The secondary prevention data is stronger with EMPA, but the overall data about primary, secondary, heart failure, renal, and prevention of diabetes, all that data is stronger with dapagliflozin. So I think both the gliflozins are comparable. Amongst the DPP4, as Parag rightly told, sitagliptin is like Sita Mata, very, very pious, very pavitra, because it does not have any blame. No renal blame, no cardiovascular blame, no skin-related side effects, no bullous pemphigoid, which is seen with Vilda and tenaligliptin, no QT prolongation. So as far as the safety is concerned, there is no doubt that sitagliptin is most tried upon and the safest molecule.
Sanjeev, but there is one question always comes, that if the Sita and Lina had such a robust data of cardiovascular safety, why still ADA had put a black box warning against all gliptin, using particularly in patients with heart failure? Because data was seen only with hexagliptin, and there was no data, such data had seen with the linagliptin and with sitagliptin also, non-inferiority. So why it had shown like this? They still don't want to use in the patient who have heart failure, particularly. I'm not talking about with established cardiovascular disease, still you can give. But what about that?
Yes, I think it is unfair, especially for linagliptin, because in the Carolina as well as the Carmelina, the heart failure risk was not increased with linagliptin. Though in the initial studies, there was some increase in the risk of heart failure with all the gliptins, but it never reached statistical significance. Somehow, I'm not very sure what was the reason why linagliptin did not get the heart failure clearance. In the TICOS trial, it was absolutely neutral. So probably neutrality did not impress the US FDA. But in the Carolina, I think there was 10% benefit, statistically, though not significant, but at least there was trend towards improvement in the heart failure hospitalization in the linagliptin. But I'm not very sure why they did not give the clearance. If anyone of this panel knows this, I would be very eager to know about it. Once yourself.
Dr. Ramesh, Shrikant, or Vivek, any one of you can give answer. If you have the data to show that a subgroup analysis where the patients who were put on a empiric outcome trial or in a DAPA heart failure trial, many of them might be on a gliptin, and then they were started on a SGLT2 inhibitor. Was there any difference in that subgroup analysis who were on a dual drug, in a combination drug with a established cardiovascular disease in compared to the patients who were not on a dual drug? Was there the equivalent benefit of SGLT2 inhibitor was seen, or was there less benefit was seen in the patients who were in combination, or was there a increase in hospitalization was seen? Because that will give you a better idea whether there was any benefit or not. I don't even know the subgroup analysis at any time came, but it is just for the, because a lot of combinations are coming. So doctors are asking, suppose if there's a patient with heart failure, should I start a patient of this combination? Should I start the patients only on SGLT2 inhibitor, or should I use GLP-1 and SGLT2, not the gliptin, as it has got a black box warning? We know that why it is given, we don't know, but still it is there. So I mean, Shrikant, Vivek, or Ramesh, if you want to make any comment, please.
Yes, sir. If we see the Q10 product insert, still there is a black box warning for using in a heart failure patient, though it is a combination of a good molecules, dapagliflozin and saxagliptin. Because that saxagliptin using in a combination, even with the dapagliflozin, we don't know that how it will affect the beneficial effect of dapagliflozin in terms of heart failure, and therefore still there is a warning that it should be used with cautious in patient with heart failure. So definitely with saxagliptin, we are very cautious, but with the use of sitagliptin or linagliptin, when there is no sign of increase in risk of heart failure in the data, CVOT data, even in a combination when we are using, we are very confident that there might be no increase in heart failure or.
Do we have in insert peg for sitagliptin and for linagliptin also a similar type for Indian? I'm not talking of US because it is there already in US market, but for Indian packing, do we have the similar type of warning or cautions written that don't use it in heart failure?
I don't think I never.
We'll have to go through the abbreviated information.
Okay,
I'm not very sure.
You and Shrikant wants to make any comment on this? Okay, do we use this combination with a patient with established heart failure? Would you like to add both the molecules together, or would you wait for one by one? I mean, with the established heart failure, I'm talking of. I had seen a patient with a 25% ejection fraction. A newly detected diabetic patient had come to us with heart failure. Patient was not knowing that he is in diabetic. Patient was already started with sacubitril valsartan, and patient was referred to me for correcting the, for the sugar part. So
Yeah, so
add suspicion one.
when it comes to new initiation in a patient with established heart failure and low ejection fraction, then my choice would be that I will start with a SGLT2 inhibitor first. And if glycemic targets are not met after adding a SGLT2 inhibitor to metformin plus minus metformin therapy, then I may go for any of this DPP4 inhibitor like sitagliptin or linagliptin, because as previous panelists have discussed, that none of the trial with the linagliptin cardiovascular outcome trial I'm talking and sitagliptin have shown increased risk of hospitalization due to heart failure with any of this. But when it comes to other gliptins, I would be skeptical.
So Srikant, I mean, you want to make any comment on it or?
Same here, sir. I feel, sir, together, since the launch of this combination and just because the combination has become cheaper, because the usage has increased so much, what has happened that in last probably 1 week, 2 weeks only, there are 5 patients where we needed to discontinue the combination. Just they got so much uncomfortable with the combination. Whether it could be a rapid HbA1c drop resulting into severe hypoglycemias, or it was unexpected. So I really feel, and in general, I'm against this combination to be started together. Because sometimes the change in glycemic is so rapid and so much that patients sometimes are not just comfortable with the entire change of the plan. I feel starting it one by one it is much more useful compared them starting together. I think that the molecule, the combination is very useful when both the drugs are there in the patient, and then you want to reduce the pill burden, and patient is already on both the drugs for quite some time.
No, but Srikant, that is like that you started with SGLT2 and when you want to add the patient on a DPP4 at that point of time, you remove this molecule and you add a combination drug. So, I mean, the number of pill is not increased. Patient is happy that he was on one drug and now still he is on one tablet, but you have, increased the actually molecule.
Fine, sir, fine. So addition of a DPP4 is never a problem. We have discussed for last 2-3 years since the lockdown that it is a product where you can add and forget about. The problem is with the SGLT2 inhibitor. Any combination with SGLT2 inhibitor has to be seen that SGLT2 is there. That is a drug we are still learning about. That is a drug that changes so many things that even with all the good properties of the product, that we patients still get uncomfortable. Whether it is a rapid, whether it is a
Because it will be rapidity of sugar will decrease, once the sulfonylurea and SGLT2 will come in combination. One company had asked me for doing a study. I told it is not possible. I am not going to do anything for you. But this type of combination, irrational combination will also come in our country. That time we will see that this rapidity of sugar fall will be much bigger in compared to the patients who are on DPP4 and SGLT2.
Exactly. So sugar control is important. Just that we have to see that patient does not land up into opposite side. So HbA1c was 11. The combinations are patient went into 60. So these are very powerful drugs, and we need to understand that even at whatever HbA1c you might add, patient can still land up into a. It was really not expected, but then this happened. So that is why I'm really skeptical. But yes, DPP4 can really be added anytime. We have to play with SGLT2 safely.
Good. So now the question comes why? And this I'm going to ask to Dr. Sanjeev Phatak. Why gliptins? Why SGLT2 in type 2 diabetes? Why we were not happy with the good controlling molecules like sulfonylurea? Why we were not happy with alpha glucosidase inhibitor, which is also independent of its mechanism of action, is nothing to do with beta cell. Why we were not happy with only metformin, and why we were not happy with insulin. When we have done a UKPDS trial, we had used only the metformin, sulfonylurea, and insulin. Still, we could achieve the patients with newly detected diabetic patients, and it had also shown there is a decrease in complications too. So why SGLT2 and why gliptins? Even gliptin had not shown those many benefits, except it does not cause hypoglycemia. And still, it is not the choice of drug. And for SGLT2, you may show that yes, it is. Why? Because it established cardiovascular disease, yes. But why we are using for a patient who is just started with diabetes? I mean, there is no cardiovascular risk factor. With a multiple cardiovascular risk factor, with established cardiovascular disease, yes, you are right that you should give these patients on SGLT2, but why for all patients? So why all type 2 diabetic patients should be on gliptin and why all should be on SGLT2, which is had become like a now like har ghar mein tiranga aisa ho gaya. There's a similar way each and every diabetic patient should be on gliptin and SGLT2.
Once your question has been partially answered, and if you allow me, I'll try to use some of the slides provided by Ajay Bhai to answer it.
Please, please.
May I be allowed to share my screen?
Yes, you can share now.
Okay.
Alex Nirav, please allow Dr. Sanjeev Pathak.
Yes, sir. It is already done, sir.
Yes, sir, it is done.
Okay. To see the sorry, just a minute. Sorry. Yes. Okay, so is my screen visible? Okay.
Yes, sir.
I'll just run through the slides very quickly. As Bansi, you rightly told that why we need, when so many drugs are available, why we need both gliptins as well as SGLT2 for almost all our diabetic patients, and whether it is relevant to each and every diabetic patient, even if they are low risk. We know the limitations of the drugs, metformin, though the gold standard. Sometimes we have to discontinue it, not sometimes, very often, I think in more than 10% of the patients, because of its gastrointestinal side effects, mainly intestinal. Lactic acidosis will not discuss, it is very rare. Sulfonylurea and the glinides are associated with hypoglycemia and weight gain. Glitazones, again, weight gain, the heart failure risk. And the alpha glucosidase inhibitors, they are very good drugs for postprandial, but again, they have to be used 3 times in a day, and the GI side effects are again very common with them. The GLP-1 analogs, though gold standard, are very expensive, associated with significant GI side effects, and are injectable except for the newly launched oral semaglutide. So with these drugs having this much limitations, we needed a drug which is very, very safe. We got a very good reply in form of gliptin, in form of sitagliptin, I would say in particular, that it is a very safe drug. You just give it and forget. You do not have to modify the dosage also unless the GFR falls. Based upon glucose, we do not adjust the dose of sitagliptin. Similarly, in the SGLT2, we got a surprising but a consistent benefit, not only cardiovascular, but also renal, also weight reduction, some blood pressure reduction, hepatic fat removal, probably indication of NASH also. And in addition to that, now we are coming up with benefit in the sleep apnea, which is very common in all our obese diabetic patients. Stone formation is also reduced. Sodium hyponatremia is also corrected. So many benefits you have with SGLT2 that we should not restrict this drug only for the patient with established cardiovascular disease. We know diabetes is a cardiovascular disease. Diabetes today means a heart event tomorrow. If not heart attack, then heart failure. And this drug has time and again shown benefit in reducing the hospitalization for heart failure. So I think better use it early rather than keeping it as a reserve drug. Now coming about why we need those drugs. As I already told that we are typical Indian phenotype. We are thin fat Indians. We have high fat content in our viscera. So we need an agent that would remove it at least to some extent so as to improve the insulin resistance. The overall benefits of SGLT2, I forgot to mention about the uric acid, but rest of the things I already discussed. They are so tremendous, and very importantly, they are seen in the clinical practice also, not only in the clinical trials. Unlike statins, which obviously we believe in, but the benefits are seen in the clinical trials. In day-to-day life, you do not see the benefits of statin on cardiovascular outcomes. Whereas the SGLT2 benefits, you can see in your day-to-day life in your patients once they start using it. I agree with Dr. Shrikant Somani that still, in a number of cases, we need to withdraw this drug because of the genitourinary side effects, or sometimes due to the volume depletion. But otherwise, the drugs are overall well tolerated, except for the genital urinary tract infections. So I'll not go into details of all these slides. You know all this. The other 3 gliptins were associated with either neutrality or some increase in the heart failure risk, but not sita or the linagliptin. Even vildagliptin, we know from the VVHF that there is some signal of increase in the heart failure or the end diastolic volume. As far as the Sita and Lina are concerned, they are absolutely safe. So the combination definitely is here to stay. Whether to use it as a fixed drug combination or separately, it is to be individualized. You have to make a decision based upon the patient needs. Over to you, Bansi. I'll stop sharing.
Oh, yes, sir. Yes. So you very correctly said that why they are required. And that's very important as evolving science and at the same time evidence-based medicine, whatever the new molecule is coming, it comes with few extra benefits. And one of the biggest reason why our diabetic patients were not getting good control was, and hypoglycemia was limiting factor for them. We can't get a good control of diabetes because the molecule which were available to us were sulfonylurea and insulin were causing hypoglycemia. Even we know that since years, if you can achieve a HbA1c of like a non-diabetic level up to 6 or below 6, you will not find even microvascular complication to occur. We know that macrovascular complication is just not dependent only on glucose. There are many other factors which are also responsible for it. But definitely a good glycemic control is going to reduce that complication part also. So hypoglycemia was limiting factor and we were looking for a molecules which does not cause hypoglycemia. So I think one was that. And then we had used these molecules with the less side effects, as you had rightly said, with glitazone, with AGI, there were side effects which were less in compared to that. But still we are finding a lot of side effects with the patient who are on SGLT2. And for that, because they are giving so much benefit as far as CV protection is concerned, as far as renal progression of disease is concerned, where it is also halted by using SGLT2 inhibitor. Sometimes we keep on explaining the patients about the hygiene part and we try to reduce the incidence of infection, but still some of the patients we had to stop it too. And that's a real fact that many of us are using for so many of our patients. And we find that some of our patients is really stopped. I think we should have one more a real world data that for how many patients who are getting it and for how many patients we have to stop it. And after starting again, how many of our patients who are getting it again and where we have to stop it completely. So that's very important, but still Dr. Ramesh, Dr. Vivek, Dr. Paraksha or Dr. Shrikant, if you want to make any comment on why we should use gliptin and SGLT2, if you want to make or you want to add anything, please.
You talked about hypoglycemia risk with the sulfonylureas. And the other thing which was noticed by the patients was that as the blood glucose control improved, they used to gain weight and they used to blame the therapy for weight gain. So for first time we have therapy which causes good glycemic control and do not cause weight gain.
So it's a type 2 diabetes with a weight gain is a major challenge. As we know that 1% decrease in A1C with a 3 kg weight gain is almost nullify the benefit of decreasing the A1C also. So very rightly told by Ramesh that it's a weight gain is a second major limiting factor. And we were looking for a molecule which does not cause the weight gain too. Yes, Dr. Parag, Dr. Vivek, Dr. Shrikant, if you want to make any comment that why we should use SGLT2 and gliptin.
I think gliptin mainly for the weight neutrality, no hypoglycemia and excellent tolerability. I think after a very long time, we got a drug which is excellently tolerated. That is the advantage why we are using more and more GP4 inhibitor. And SGLT2 inhibitor, I think glycemic, pleiotropic benefit, metabolic benefit, and cardiorenal benefits. I think all the reasons except the genital mycotic infection. Some patients lose significant amount of weight actually. For the weight loss, we have to stop the drug. That is also a common scenario that somebody who is 62 has become 54 and 10 people tells that patient that, okay, what has happened to you?
Yes,
you are looking weak and tired and you are...
That's also one of the reasons that some of the patient does not want to continue it.
Yes, one of the reasons we have to stop because of the weight. Even somebody of 80 kg becoming 72 kg, still overweight, they want to reduce. Stop the drug.
સાહેબ 5 કિલો ઘટી જાય તો પરેશાન બૂમાબૂમ કરી
અને એ પેશન્ટ કરતા છે ને 50 સગા કહેશે અને ઓળખીતા પારખીતા સાહેબ
મારો તો
શું થઈ ગયું તમારે શું થઈ ગયું તમને
અંડરવેલ જેવું હતું આમ ભૂકી અને he told કે સાહેબ મારો વજન 110 કિલોનો 5 કિલો ઘટ્યો તો કે ના મને નહીં ચાલે કે કેમ કે મારો હવે વજન નહીં પડે નો મારો તો વજન જ પડવું જોઈએ that is my business if I am going to reduce the weight how it is going to work. So we know that this is individual problems, but we know that weight gain is again a challenge, and this is the molecule which has got a benefit, like one weight neutral, other is weight losing the molecule. That is real advantage. Srikanth and Vivek, why we should use SGLT2 and DPP4 in our type 2 diabetic patient? That's the question second.
Yes, I think, sir, everything has been mentioned. Low risk of hypoglycemia, low risk of weight gain, even some weight loss, which is expected. Cardiovascular neutrality, excellent safety profile. The combination usage, I think, what it will give us the benefit extra is that sometimes the individually using DPP4 inhibitor or SGLT2 inhibitor, the reaching the target of HbA1c less than 7, sometimes difficult with the individual drug, especially with the HbA1c in the range of 8.5 or up to 9%. At that point of time, using a fixed drug combination at the start of therapy will give us the confidence to reach that target HbA1c of less than 7% in the initial part, and the inertia of the therapy, that sequential therapy, gradually we go up titrating the therapy and adding a different molecule will not be there, and patient will achieve rapid glycemic control easily.
Yes, sir. So now the last part, when we should use gliptin, when we should use SGLT2, and when we should use the combination. That's a question, and then we will be taking some questions which is asked by our participants. Now we have more than 250 participants who joined. So really, congratulations to ACMEDICS as well as all the faculty members. Because of you, they have joined today. So Dr. Ramesh, that's question to you. When we should use gliptin and when we should use SGLT2 and when we should use the combination.
Yeah, so good evening and thanks Bansi for giving me the opportunity. And I will share my screen. I will show
Yes,
slides if you allow.
please.
So basically, this is a tough call that when to use a DPP4 inhibitor and when to use a SGLT2 inhibitor. But if I go with my natural choice would be that I would be more comfortable with DPP4 inhibitor because as Parag Bhai rightly said that the side effect profile is virtually identical to placebo. And my faith in DPP4 inhibitors increased during the COVID period when I was doing a lot of teleconsults, and I used to frequently prescribe a DPP4 inhibitor metformin combination. And patients used to do very well glycemic control wise, and they were not bothered with the side effects also. So after decades of use of DPP4 inhibitors, my faith increased it during the COVID period. But we have to keep the guidelines also in our sight when we are choosing a molecule.
Ramesh, your slides are not moving.
No,
Yes.
now I'm moving. Yeah. So now this is the first slide. So we have to keep certain comorbidities in mind when we are choosing a particular agent. So metformin is undoubtedly the first line agent for almost all patients with type 2 diabetes. So first line therapy is metformin and comprehensive lifestyle modification. Then we have to ask ourselves a question that is patient having indicators of high risk or established atherosclerotic cardiovascular disease, CKD, or heart failure? If answer is yes to any one or more of these conditions, then you have to choose either a GLP-1 RA with proven cardiovascular benefit or SGLT2 inhibitor with proven cardiovascular benefit if GFR is adequate. So when we talk about the GLP-1 receptor agonist, we have limited choice as far as this indication is concerned because as of now only liraglutide and dulaglutide have proven a cardiovascular benefit. Oral semaglutide has a neutral data as far as the cardiovascular outcome trials are concerned. So we have to either choose an injectable GLP-1 RA, or we have to settle for a SGLT2 inhibitor with the proven cardiovascular benefit. And if heart failure or CKD predominates, then the natural choice is a SGLT2 inhibitor with proven benefit for heart failure and CKD. You can choose either of the SGLT2 inhibitors. All the SGLT2 inhibitors have shown consistent benefit in heart failure or CKD, but the evidence is more in favor of dapagliflozin when we talk about this comorbidities in particular. And if the requirement is to reduce the risk of hypoglycemia, then after metformin, you can choose either of these agents. You can choose a DPP4 inhibitor. You can still choose a SGLT2 inhibitor, even if a patient is not having any established cardiovascular disease, CKD, or heart failure. Just for glycemic control benefit, you can choose this agent. And you can choose a TZD, but the TZD has issues of the side effects which should be kept in mind, and the issue of weight gain. Now let us move further right. If the compelling need is to minimize weight gain or promote weight loss, then we have only two choices. Again, a GLP-1 RA, which has proven efficacy for weight loss. So currently all injectable and the oral GLP-1 RA available in our country have the proven benefit. You can choose any of them, but they are expensive. And the second choice comes as SGLT2 inhibitor. So again, you can choose any SGLT2 inhibitor because all SGLT2 inhibitors have proven benefit as far as the weight loss is concerned. And if cost is a major issue now in India, it's I will say a luxury to treat a patient with type 2 diabetes, because barring GLP-1 RAs, all other group of the agents are available at a very affordable cost. So if cost is a major issue, you can choose either of the agent barring GLP-1 RAs. So these are the drug-specific and patient-specific factors to be considered when selecting a hyperglycemic agent. This has already been discussed, so I'm not going in detail of this table, but just to highlight that the benefit of hypoglycemia risk reduction and weight reduction are seen with agents like SGLT2 inhibitors and GLP-1 RAs, and the risk of hypoglycemia is also reduced with agents like DPP4 inhibitors. So these are the two parameters we should keep in mind when we are designing a therapy for type 2 diabetes. So this is how the algorithm goes. So if a monotherapy with metformin fails and you're thinking of a dual therapy, then you can choose a DPP4 inhibitor with intermediate efficacy, low risk of hypoglycemia, weight neutral, rare side effects, and cost effective in our country. And for SGLT2 inhibitor, again, intermediate efficacy, hypoglycemia risk is low, then it causes weight loss. It has a certain genitourinary side effects which should be kept in mind. And the cost is now economical in our country. And as the previous panelists have mentioned, that if you combine these two drugs, then the intermediate efficacy of the individual agent, when you combine both of them, it may increase to high efficiency. Now, just a few slides about dapagliflozin. It is not associated with increase in risk of cardiovascular events. So here you can see that use of dapagliflozin had a similar number of major adverse cardiovascular events as compared to the controls. Renal function was stable over time with dapagliflozin. And these are the patient selection criteria for therapy with SGLT2 inhibitor. Patient not on HbA1c target, patient overweight or obese, difficulty in controlling blood pressure. So this is a pleiotropic benefit, and patient having adequate renal function, that is eGFR of more than 30. So these are the RSSDI guidelines. So basically RSSDI guidelines, they support the use of SGLT2 inhibitor as a first-line agent. SGLT2 inhibitor instead of DPP4 inhibitor should be preferred if SU or TZ is not appropriate. If A1C is more than 7.5, DPP4 inhibitor, SU, TZD, or SGLT2 inhibitor can be used as second or third line agent. And this is the snapshot of the clinical trials of various DPP4 inhibitors and SGLT2 inhibitors. So, as already discussed for sitagliptin, we have a TCOS trial, which was published in 2015, which showed the safety of sitagliptin in patients with established cardiovascular disease. And with dapagliflozin, we have the DECLARE-TIMI trial, then we have DAPA-CKD trial, so DAPA heart failure trial. So these are various trials which have shown the efficacy and safety and benefit of dapagliflozin in patients with CKD or heart failure. 5 benefits, important lever to treating Indian phenotype. So fast action, if you use these agents, then they start acting immediately. Glucose lowering effect is significant and sustained. Weight loss and BP reduction is the pleiotropic advantage. We can see the flexibility, insulin independent mechanism of action with less chances of hypoglycemia. And other benefits are proven cardiovascular, renal, and other pleiotropic benefits. So those were my slides, Dr. Vansi, and I will stop sharing my screen.
Thank you, Ramesh. Very rightly said. And you had shown the ADA-ESD guideline as well as also you shown the NICE guideline and Indian guideline when they should use. Just to tell about the Indian guidelines and RSSDI guideline, we have divided with A, B, C, D, E, F, G, S. A is the age of the patient. The patients who are elderly where probably a DPP4 can be a choice of drug with a higher BMI. Again, SGLT2 is better in compared to DPP4, but in combination, DPP4 found to be also weight neutral. In combination, they also decrease the weight. C is with a patient with CKD in early course. SGLT2 had shown the benefit of further progression, but with established CKD with the eGFR is going less than 20, still the gliptin is the choice of the drug. For the patient with CKD, it can be used at any level of eGFR. When the duration of diabetes is more, again, both are effective. It has been shown initially that gliptins are effective only when duration of diabetes is less, but then it had shown that even the patients who have 15 years, 20 years of diabetes, definitely they will have some benefit of using gliptins because they have a glucagon suppression effect too. But SGLT2 inhibitor, as the mechanism of action is not dependent on beta cell, it can be effective even at the level of the 20, 30 years. And now we have seen the data with type 1 diabetes too. So it does not depend on the duration of diabetes. E with established cardiovascular disease, at present, it is the safety and the benefits are more with SGLT2 inhibitor. F is the finance is now no more a concern for the molecules like DPP4 and SGLT2. Both are available at a very nominal price to our country. G is the glycemic control more with SGLT2 in compared to DPP4, but DPP4 had shown in Indian data that it is found to be more effective in compared to the Western population. And last is H, which is risk of hypoglycemia, which is very, very less with the patients who are on SGLT2 and DPP4. Just to summarize the complete RSSDI guideline, which we have started with ABCD, EFGH. There are a few questions which I am starting because not discussing on when we should use. It is already Ramesh had talked where we should use, but Dr. Devan is asking, can this gliptin and SGLT2 combination, fixed dose combination, can cause hypoglycemia who are not on sulfonylurea insulin? Anyone? DPP4 had shown some data to decrease, I mean, it can lead to hypoglycemia, 2% to 3%, but anybody wants to make comment? Sanjeev bhai.
Well, theoretically, it should not. But in practice, we see that mild hypoglycemia can occur with any antidiabetic drugs, except acarbose or glucose, which are actually anti-hypoglycemic. But otherwise, some susceptible patients or labile patients can develop hypoglycemia even with DPP4 metformin combination. And that we have documented also, blood glucose going down to 60 or 50 also. But it is not common. We have not seen any patient getting hospitalized due to severe hypoglycemia from these drugs. if there is no sulfonylurea or insulin on board. So even if you use combination of DPP-4, SGLT2, metformin, pioglitazone, hypoglycemia is rare, though it may sometimes happen, especially if you are using a quinolone-like drug with this, hypoglycemia can occur. So
Yes,
one
correct.
should not totally discount hypoglycemia, but it is not common. That would I say.
Dr. Parag, adding pioglitazone to SGLT2 inhibitor, is it beneficial in terms of countering the weight gain and fluid retention? Dr. Rukesh is asking.
Pioglitazone, as we all know,
Ah.
increases the weight in certain subset of the patients. Those who have mild weight gain because of the pioglitazone, if you add SGLT2 inhibitor, the weight gain of the pioglitazone is nullified and patient lose some weight. But if the patient has a significant weight gain because of the pioglitazone, and if you add, say, more than 5% weight gain, and if you add SGLT2 inhibitor, the weight loss is not that much compared to not giving the pioglitazone. So it will nullify in those patients who have mild weight gain, but it will not nullify the effects of weight gain if there is a significant weight gain because of the pioglitazone.
And that
This
is
is a
again,
clinical observation.
and that is again, you can't predict that how much weight gain
Yes,
one
yes.
patient will have and how much somebody will have a weight loss, and whether this patient by adding these two molecules together, there won't be any weight gain. You can't just
Yes.
promise the patient that this is going to happen. Is
Yes.
Srikanth, Vivek or Ramesh, you want to make any comment on this? Quick comment if you want, otherwise we can take the next question. Which group increases the LDL cholesterol, Dr. Ramesh? I mean, out of SGLT2 and DPP4, GLP1.
SGLT2 inhibitor may increase the LDL cholesterol slightly, but it has a beneficial effect on HDL and triglyceride. So overall, if we talk about the atherogenic lipid profile in patients with diabetes, overall there is improvement in lipid profile with SGLT2 inhibitors also, but there is a issue of a slight increase in large buoyant LDL. It's not small dense, it's large buoyant LDL with SGLT2 inhibitors.
Vivek, question to you. Adding SGLT2 with an overweight and obese patient is fine. But what about the patient who is lean or patient who is below, normal weight? Would you like to add as an anti-diabetic, as an anti-heart failure therapy in both the conditions? Suppose a patient who comes only for sugar control, would you like to add? Would you like to add this patient who is lean but multiple cardiovascular risk factor? Or would you like to add SGLT2 inhibitor because that lean patient is having heart failure? Now, 3 questions to you, Vivek.
So in this kind of patient, if there is a hard indication to use SGLT2 inhibitor, especially if patient is having heart failure, CKD, or established atherosclerotic cardiovascular disease, which are the hard indication to use SGLT2 inhibitor, we may start with a lower dose of SGLT2 inhibitor because the benefits has been seen in across the all BMI subgroup, whether the patient is having normal BMI, overweight, or obese subgroup. If using for only anti-hyperglycemic agent in a lean or underweight patient, I would be reluctant to use unless there is a hard indication. If there are other therapies which are there, which are really helpful
So these lean patient could be even severe insulin deficient also, SID patient.
Yes, yes. So
Better,
insulin deficiency, it is
avoid.
again.
So
Yes.
unless a patient is having CKD and the patient is having a hard indication to start with, I fully agree with you. Dr. Srikanth, if somebody is already on a quadruple therapy, sugar is not controlled, would you like to add SGLT2 inhibitor for a glucose control? Will it be appropriate, or would you shift here? This is the time the patient should be shifted to insulin therapy. When you want to add the SGLT2 inhibitor, what will you do with that patient? Quadruple therapy already. Patient sugar is 9, 8.5. Will you add this as a fifth molecule? What you will do?
8.5.
Yes, I'm just giving you a theoretically.
Yes, fine, sir.
8.5.
Exactly. So I was just dividing it. So patient is on SU, metformin, and voglibode and
Metformin, gliptin, and SGLT2. 4 drugs
gliptin
are
and
gliptin, AGI,
AGI.
metformin, and
Absolutely.
sulfonylurea. 4 drugs are already there with 8.5.
With it, I'll add directly in insulin therapy.
Okay. Insulin, and then you may change the therapy, may not now add all these things, and SGLT2 can be added, But here it will not be added only for glucose control, and you will not avoid insulin therapy in this particular situation. Am I right?
Absolutely, absolutely. Even if the patient is having I'll say an established cardiovascular disease, still the glycemic control first point is very very important. And once we have attained a even satisfactory glycemic control in probably in a month, not we have reached a target HbA1c, and then probably slowly adding an SGLT2 inhibitor would be my plan. So, but yes, once the glycemic control is best and targeted by insulin.
Dr. Anusha is asking which gliptin and glyphosine is combination is better, sita-dapa, vilda-dapa, and tenali-dapa, but that I think already been discussed when Parag was talking about. At the present, we have the best data with sita and dapa, or with EMPA and with linagliptin. Dr. Jignesh is asking, can we use this gliptin and SGLT2 combination or either for first-line therapy in a newly detected diabetes, even before metformin? He is not talking only SGLT2, which is European Society of Cardiology has endorsed that combination, along with ESD was further endorsing that thing, that you start with the patient with SGLT2 with established cardiovascular disease before even you start the patients on metformin. But he is asking that combination of these two before starting the patients on metformin. Anybody wants to take it?
I don't feel so. Yes, sir.
Yes. I think everyone will be on the same page, not without metformin.
So if only except the metformin intolerant patient you can think of, otherwise don't think of it. That's what at current present scenario and with the guidelines. Tomorrow it may change because it's a evidence-based medicine and every day it is evolutionary. That's the reason we are keeping so many educational programs. Dr. Jignesh is asking, is there any someone who is weight is more than 100 kg? Would you like to add, increase the dose of SGLT2, or this is the highest dose? Or would you add gliptin also in a higher dose, like teneligliptin people started using 40 milligram? So will you increase the dose of gliptins or SGLT2? If somebody wants to use sitagliptin, dapagliflozin twice daily, will it help the patient who is above the 100 kg?
I think it will help the company, not the patient.
It will help the company, definitely.
We can use canagliflozin.
You can add the two different company, two products.
Recently only, I think a trial is published. I think it is featuring you also, that teneligliptin 40 milligram does not offer any
benefit.
over 20.
Yes,
right?
Very true. So with these few questions, I think if we can end, it's already 10:30. If any one of you want to make any comment, a quick comment, otherwise we can end the program. I will just...
a very quick comment from me. I think we should not target the number 7 now. With the agents which do not cause hypoglycemia, we should be targeting near normal glycemia rather than 7 or 6.5 being the number. Your comments.
One is that the A1C target should be dependent on what therapy you are starting.
Absolutely.
Or the way which we had, before few years, ADA had gone back that it is not the 7.5 or 8 is fine. Similarly, less than 7, which are the condition when you should target the A1C less than 7. So the point is, a patient who is sitting in your clinic, you should decide that for that particular patient, what should be the target A1C. Suppose I have a patient who is frail, who is 75-year-old, risk of hypo is very high. I may target less than 7.5. No, less than 8 is okay. But I have a patient relatively young, and still the risk of hypo is very high with cardiovascular disease. Even 7.5 is okay. Normal patient, I may go with 7. No hypo with the very aggressive agent, 6.5. But if a patient to whom I am starting only on metformin, gliptin, and SGLT2, where the risk is very high, low, I may go the target A1C even 6 or below 6. Is it the point, Sanjeev?
Yes, absolutely.
I think that we can put in the somewhere, but can we have the more data for that? If you are keeping it less than 6 or keeping it less than 6.5, do we have a long-term data to show that it does not cause, long-term complication? That's a challenge. Parag bhai.
I think logically, the pre-diabetics have more chance of macro and macrovascular complications, specifically macrovascular
Yes,
complications.
logically it goes.
So logically, it's yes, but I think it is very hard to have the long-term data.
Very true.
That comparing the A1C 6.5 to 7 versus 5.8 to 6.5 and 5.8 or below.
But
I think-
pre-diabetic patients have also high risk, so it's better to keep
Exactly,
it
yes.
non-diabetic
So
risk.
that is what and I think Dr. Sanjeev also, all of us are doing now is
We
in
do
a
in
patient.
clinical practice, but it had not come in guidelines. So that is what.
Yeah, it will not come in a guidelines unless you got a hardcore data.
And
I think
sometimes
with
what I am
addictive
thinking,
to-
Sanjeev bhai, they people are very much insurance dependent. I mean, they
Yeah.
will not put why they are putting a start with one drug, because if two drugs they put, insurance company has to pay for the two drugs. When metformin alone can control the sugar HbA1c by below 8, they will not allow that patient to go more than 8. I mean, you just give the metformin only this patient because he can be controlled only with metformin. Why you are adding the second drug? Because insurance company has to pay there. So, I mean, yes, this is definitely, it can be changed that you can start with early combination, better to achieve a tighter glycemic control. And these are some of the things which can come in Indian guidelines too. I fully agree. Anyone else wants to make any other comment? If no, then I can propose vote of thanks to all you experts. We are very thankful and grateful to all our experts, Dr. Sanjeev Phatak, Dr. Parag Shah, Dr. Vivek, Dr. Shrikant Somani, and Dr. Ramesh Goel for sparing their very valuable time. It is almost like 9:15 to 10:30. And also I am thankful to all the delegates, all the participants from Gujarat, all over Gujarat, more than 300 delegates who logged in. And many of them are very interactive and they ask so many questions to us. So it's really very much thankful. Once again, thank you to Acmedics, particularly Nipun and Ajay Bhai for this opportunity which they have created. And this thing, online continuous medical education is the one of the best way to disseminate the knowledge, and with most cost effective, the way we have created cost effective DAPA and sitagliptin and cost effective combination. Similarly, this cost effective way of disseminating knowledge is the online and attending this CME online. That is the best way. With these few words, I thank once again. Thank you, everyone. Good night.
Good night.
Good night. Thank you. Thank
Good
you,
night.
everyone.
Good night.
Respected chairpersons, experts, moderators, coordinators, and all delegates. On behalf of Acmedics, I wholeheartedly thank you all for sparing your valuable time to bring out the consensus on gliptin, gliflozin, which, why, and when. Hope the abstract presentation and the tips by the experts will help at large all practicing physicians. Since last 12 years, we all were waiting for a brand of sitagliptin, dapagliflozin, and FDCs, the fixed dose combinations, at a very affordable price for Indian patients. And now, your long wait has come to an end. With our expertise of 36 years in the field of manufacturing, we could give to the Indian patients these new molecules and its combinations at a very affordable price. No wonder it is world's lowest. Yes, this is vocal for local. India can do it and we have done it.
Thank you.
Once again, it's my personal thanks to all of you and especially to Dr. Bansi Sabu, Dr. Parag Shah, Dr. Sanjeev Phatak, Dr. Ramesh Goel, Dr. Shrikant Somani and Dr. Vivek Patel for helping us to organize this interesting webinar. I assure you in future, we will be the front runner to such academic meetings. Thank you and good night to all of you.
Bye, boss. Thank you. Bye, Vivek. Thank you, Shrikant. Bye-bye.
Good night, sir. Thank you so much. Thanks, sir.